Hey guys, this is Caesar with Nursing School Made Easy. Today's lecture is going to focus on COPD. Now, again, I'm going to make this very basic and very fast. Again, this is geared towards preparing you for the NCLEX exam, so I'm just going to hit you with the main points that you need to remember. But first of all, let's get into what COPD is, the pathophysiology, some of the anatomy behind it. Now, COPD is really a combination of two things: bronchitis and emphysema. So we're going to talk about those two things here in this lecture as well, and how it all ties in with COPD. So again, bronchitis and emphysema. And so let's tackle these one at a time. Now remember that you have your trachea. So this is my trachea here. And the trachea is going to bifurcate into your main bronchi, your main bronchus. And also remember that inside your lung, these are going to, this is our main bronchus here, this is also going to continue dividing or subdividing, getting smaller and smaller. And so it'll turn into the bronchioles. Now remember, oxygen is going to come in, it's going to separate, it's going to go into your lungs, okay? And so again, these are our air passages, our airways. So again, oxygen is going to come in. So if we take this image here, zoom it up. So this is how oxygen travels. Okay. Now at the end of these bronchioles, you have a bunch of little clusters. Think about grapes or raspberries. That shape has got a very bubbly shape. At the end of these, you have little air sacs called an alveolus, singular, or alveoli, many. Okay, now it is the alveoli where gas exchange occurs. And I put a couple of balloons together. And so your alveoli kind of look like this if I were to magnify them 1 billion times. Okay, and so this is where gas exchange occurs. So anytime you take a big, deep breath in, your alveoli get bigger. When you exhale, they get smaller. Okay, now notice that just like a balloon, your alveoli are very flexible. There is air in them. Okay, air, not fluid. And because these are very thin, very fragile, they can easily move. Remember that in your lung you have something called surfactant that helps move these things along. Now, however, in COPD, the main cause being smoke or smoking, remember that when you smoke, you're also inhaling a lot of irritants, things that irritate your lungs. Now in your lungs, inside of your alveoli, you have macrophages. You have things that kill anything that comes in and irritates your lung. So as a result, you have increased mucus secretions. Okay, that'll go with bronchitis. So let me write that down here. You have increased mucus secretion. And that is due to inflammation. And typically inflammation in the main bronchus or in the bronchioles especially. Okay, so you have increased inflammation due to irritants, in this case smoking. So the more you smoke, the more you're going to irritate your bronchioles. The more you irritate your bronchioles, the more mucus will be secreted. Now, if you remember in our lecture on asthma, if we were to take a cross-section of these bronchioles, flip them so that they face you, so this way we're getting a view of going, your bronchioles going this way. Well, if we were to turn it around and have it face you like so, we would find that it looks similar to this. Remember, this is smooth muscle out here. And on the inside, you have, again, mucus production. So if there's anything that irritates your bronchioles, these will begin to increase mucus production. Now, if the mucus production is severe enough, what happens? Well, the airspace gets smaller and smaller. If this gets smaller and smaller, well, what happens? You have decreased air coming in and decreased air going out. So that's one problem right there. Okay, so this really leads into what's called bronchitis. Okay, so again, we have smoke, which causes irritation or inflammation in the bronchioles. That's all really bronchitis is, inflammation of the bronchioles. As a result, you have increased mucus production, which is going to inhibit how much oxygen comes in, how much CO2 goes out. Now, I talked about how your alveoli are very, very pliable or moldable. You take a deep breath in, they expand. You exhale, they get smaller. Okay? Well, in emphysema, you have a loss in alveoli or alveolus function, loss in shape. So let's say that here we have a cluster of alveoli. Now, I also said here, if there's inflammation going in, it's going to inhibit how much air comes in, how much air goes out. Well, this prevents, again, air from moving out, from getting outside of your body. As a result, you end up with trapped air. Okay? Now, I also made a brief statement earlier that inside your alveoli you have something like macrophages. And again, these are present just in case any irritant comes in, while your immune system kicks in to rid the body of that pathogen. So again, we were talking about smoking, how this is an irritant. So you're going to breathe in smoke, it's going to cause irritation. Your immune system is going to kick in. Your macrophages are going to get triggered to come in, start acting, taking the quote-unquote bad guy out, the pathogen out. And something else comes in, your neutrophils come in. And both of these secrete what are called proteolytic enzymes. Okay, these are, think of it like acid. So these come here and they start secreting acid to get rid of the bad guy, get rid of the pathogen. Well, if you're continuously smoking, you're continuously introducing an irritant into your body. As a result, over time, yes, you get rid of the bad guy, but as a result, you will also end up damaging your alveolus or your alveoli. When these become damaged, these change shape. Now, I told you how your alveoli or alveolus moves very, very easy. Well, as these become destroyed by your neutrophils and macrophages, they lose that elasticity. Not only that, but I told you again how you have trapped air. So this trapped air, along with the destruction by your macrophages and neutrophils, causes that change in the alveolus, or also known as emphysema. So that is essentially what emphysema is, a destruction or a loss in shape in the alveolus. Now, because there's a change in the alveolus, there's a destruction, air cannot get in, oxygen cannot get in, so you have decreased airflow or airflow limitation. At the same time, CO2 cannot get out, so you have something like hypercarbia or increased CO2 retention. So here you end up with two things: one, hypoxemia, and two, increased CO2 retention. Okay, so make sure you remember that. Now, because there's this change in shape in the alveoli, you're having to breathe harder. The patient is having to breathe harder because they're having to force air in. The thing about COPD is that it is irreversible. In asthma, it was reversible. We give them a bronchodilator, an anti-inflammatory like a corticosteroid, and it'll change the shape. It'll reverse the effect. In COPD, once these are damaged, that's it. There's nothing that can be done. Once that shape has changed, it cannot be reversed. So that is very, very important for you to understand. Now again, because that shape cannot be reversed, patients have to, again, very, very forcefully, they pretty much have to suck air in so that it comes here, so that oxygen exchange can occur. So they have to force it. And the other thing that they have to do is they have to force air out. They have to exhale forcefully. Now, as a result of this forceful inspiration and expiration, something happens. A change in their chest occurs, and they get a barrel-shaped chest. Okay. Now, one of the problems with a barrel-shaped chest is that you're not supposed to breathe with your chest. You're supposed to use your diaphragm to breathe in and out, or to inhale and exhale. But as a result of using your chest muscles, patients get really, really fatigued because, again, your chest muscles are not designed to do that. And as a result, these patients complain of a lot of fatigue, a lot of weight loss, a lot of dyspnea. So now let's get into our clinical manifestations. So let's jump right in. Let's move on to your clinical manifestations now. The number one thing that you have to focus on is this chronic cough. And then we'll explain why, because this will lead into very, very many different things. I also talked about how smoking is the number one cause. It is not the only cause. You can also have something like air pollutants, chemical or aerosol irritants. The number one thing that you want to focus on is smoking, or any individual that spends a lot of time burning wood and stays close to that flame, stays close to that smoke. Anytime you inhale that, remember that smoking or smoke is an irritant. So you breathe that, it causes irritation. That irritation results in your bronchioles beginning to secrete large amounts of mucus. Now, remember that in your airway, your trachea, your bronchioles, you're supposed to have cilia. Cilia help remove or get rid of these mucus secretions when you cough. But smoke kills these cilia. Therefore, you lose that ability to rid the lungs, the chest of these mucus secretions. As a result, patients have a chronic cough. Because again, they're attempting to get the mucus secretions out, but are unable to. So again, they suffer from a chronic cough, a productive cough at that. Okay. Now, too, I talked about how you're going to have increased mucus secretions, which is going to narrow the bronchioles, making it difficult for a gas exchange to occur, making it difficult for O2 to get in and CO2 to leave. So you'll suffer from hypoxia and hypercarbia, or increased CO2 retention. Now, as a result of that, you end up with dyspnea, difficulty breathing. You also suffer from weight loss, and this is due to the dyspnea. Anything that causes your body to exert any type of energy, well, you don't have the oxygen supply to meet the demand because of those changes in the alveoli. So you suffer from activity intolerance. You are extremely fatigued anytime you eat. You can't catch your breath when you eat. As a result, these patients suffer from weight loss due to anorexia. Number 4, prolonged expiration. Okay, so when they exhale, it's very long. Why? Well, we talked about how the alveoli change in shape. Now, as a result of that change in shape along with the bronchioles losing. Let's talk about how, again, your bronchioles are going to have a circular shape, and in this circular shape you're going to have increased mucus secretions. This large amount of mucus secretions is going to prevent air from getting in and air from leaving. As a result, you end up with trapped air or trapped CO2. Now this trapped CO2 is going to cause this prolonged expiration or increased time in exhaling, because again, air cannot leave. Okay, so that is the reason for the prolonged expiration. Now 5, barrel chest. Now again, you stop using the diaphragm to breathe, and instead patients begin to use their chest muscles to breathe. And this is very, very forceful. This is very, very hard on those chest muscles. And throughout time, again, this is a chronic thing. This is not acute. You do not go from one day being fine to the next day suffering from COPD. It doesn't happen that way. This is a chronic thing long term. As a result, over time, you begin to use the chest muscles to breathe, to help facilitate breathing. At the end of that, the end result is a change in chest shape, or a barrel chest, because again, you're having to use those muscles to forcefully breathe in and forcefully exhale. As a result of this difficulty in breathing, you will often observe these patients being in a specific position, something called the tripod position. Again, they're attempting to facilitate or make breathing easier on them, so they'll position themselves in a tripod position. You also maybe see these patients do something called pursed lip breathing. Number 8. There will be edema in the lower extremities. Now, I forgot to mention this earlier, but this is due to cor pulmonale. So let me explain that really quick here. So we're going to say that these are bronchioles. So we have our main bronchus here. And like I told you before, these are going to get very, very small. And at the end of these, you're going to have little grape-like things or raspberry-like sacs called alveolus, or if they're all clumped up, we called alveoli. Okay. Now remember that you also have vasculature coming here. You have deoxygenated blood coming. There's capillaries here. And this is where gas exchange occurs. Okay. So blood is going to come in, and hopefully O2 will come in and CO2 will leave, and then you'll exhale that out. Well, in this scenario here, we talked about how you're going to have hypoxemia. Hypoxemia is going to cause these arteries to constrict. Okay, it'll cause vasoconstriction. As a result of this vasoconstriction, you're going to have pulmonary hypertension. Remember that blood is going to come from the heart, it's going to go into the pulmonary artery, and then those pulmonary arteries are going to get smaller and smaller and smaller, and oxygen exchange is going to take place. So blood is coming from the right side of the heart. If we have pulmonary hypertension occurring in the right side of the heart, you end up with what's called cor pulmonale. Okay. eventually this can lead to right-sided heart failure. And this right-sided heart failure is what will lead to the edema in the lower extremities. Okay. Number 9, focusing on our clinical manifestations. We talked about this multiple times. Hypoxia. So if you check your O2 sats, they will be decreased. Because they are hypoxic, they will have that bluish discoloration to their skin, or cyanosis. Now, you will have polycythemia. Now, why will you have polycythemia? Okay, let's break this down. You are hypoxemic, correct? Now, your body starts thinking, well, or your kidneys, remember they're going to secrete erythropoietin, which is going to cause hematopoiesis, or it's going to begin producing more red blood cells. Now, the reason your body does this is because it's, well, your brain is saying, hey, dudes, we are low in oxygen. Is it our red blood cells? Do we need to make more red blood cells? If we make more red blood cells, that'll increase our oxygen amount. So your body begins to make more red blood cells, otherwise known as polycythemia. So if you were to get a lab or a hemoglobin, you'd find that they have very, very large red blood cell numbers, about 20 or greater. Okay, so you end up with polycythemia. Number 12, you end up with weakness. And again, we talked about how you have activity intolerance because you don't have any oxygen, you don't have enough oxygen in the body. So you suffer from weakness or activity intolerance. Now, if you have weakness, if you have activity intolerance, you're not using your muscles, you're not putting any pressure on those bones, keeping those bones strong, long term, you will suffer from osteoporosis. And a lot of these patients, just think about it, you can't walk, you can't eat, you can't do anything really. A lot of these patients suffer from depression. So if you're a smoker, this is what you have to look forward to. So quit it, cut it out. So there's my little rant on smoking. Okay, let's move on. Diagnostic studies. In order to diagnose this, something called a pulmonary function test will be performed. So make sure you know that for the NCLEX, pulmonary function test. Okay. Spirometry will be performed. So we've talked about spirometry and pulmonary function tests in two different areas. One with COPD and the other one was asthma. Okay. Number 2, a chest x-ray will be performed. Now remember that we're going to have changes in our alveoli because you're going to have trapped air. So this will provide a very, very distinct chest x-ray. You'll do something like an ABG. You will notice hypercarbia or increased CO2 levels. You will notice hypoxemia or decreased O2 levels. So your ABG is very, very important. Talk about why a little bit later when we talk about our interventions. EKG and echocardiogram. Now these are typically done because again we talked about cor pulmonale, how the heart runs a likelihood of suffering from pulmonary hypertension, which can then lead to right-sided heart failure. So that is why the EKG and echo are done. They're done to check on the heart, see how much the heart has been affected. So these are not used to diagnose, but instead to see how COPD is affecting the heart. So to diagnose, mainly you want to focus on the pulmonary function test along with the chronic cough and their signs and symptoms, along with do they smoke or not. That's a big one. Or do they interact with any toxic fumes, any air pollutants. Number 6, you may also do a sputum culture. Now this is because, again, I talked about how you're not able to get rid of those mucus secretions that stays in the lungs. You have change in the alveolar shape. So these patients have a very, very high risk of suffering from like a pneumonia. So you always want to do sputum cultures, check to see if there is any pneumonia present, because again, the sputum culture will dictate what antibiotic therapy, if any antibiotic therapy is used. Okay. Now let's focus on your interventions here. So let's get right into it. Interventions. So what is a nurse going to do with this type of patient? Or what are you going to do more specifically? Number 1, we talked about how you're going to do a sputum culture, because again, that's going to help identify what type of antibiotic therapy you're going to give. So number 1, antibiotic therapy. Now I'm just going to name these out, and you feel free to write them down. Antibiotics can include something like azithromycin, doxycycline, amoxicillin, or levofloxacin. Again, that will be determined by the MD, and that will be determined by the sputum culture as well. Number 2, you're going to tell your patient to stop smoking. Now that is easier said than done, so again, this can be quite a task, but really you want to stop that smoking. You want to make sure that, again, if there are any cilia left, that you give them a chance to grow back. That's going to help get rid of those mucus secretions a lot easier. Okay, so again, please inform your patient to stop smoking immediately. Number 3, you would administer bronchodilators. So I can spell. Now we talked about our bronchodilators in another section when we talked about asthma. Again, if we were to take a cross section of the bronchiole, in asthma, remember that in the bronchiole you have smooth muscle out here. Smooth muscle is going to either cause constriction or dilation. Okay. In COPD, however, it's not so much constriction that causes a problem as it is the increased mucus secretions. Okay. So yes, the bronchodilators are going to have an effect. They are going to improve, but they're not going to have the great effect that they did with asthma, because again, these are going to dilate bronchioles. But here in COPD, we deal more with increased mucus secretions. Okay, so yes, it's going to help, but not as much as it did in asthma. Nevertheless, let's talk about the bronchodilators, or the beta-adrenergic agonists. I misspelled that. You'll also give anticholinergics. Something like Spiriva. You can also give something like the short-acting bronchodilators, something like albuterol, or ipratropium. I think I misspelled that. Ipratropium. Didn't say it right. Ipratropium, or Atrovent. It's another name for it. Okay. So these again are the short-acting bronchodilators. You can give these together in a nebulized form. If these are together, then that's considered a duo neb. Okay, duo meaning two. You can also give something like salmeterol or formoterol. These will typically be given by the respiratory therapist, but in case you see them on the NCLEX exam. Okay, you can also give something like the corticosteroids. Again, these are going to help out with the inflammation. Okay, if you decrease the inflammation, hopefully the bronchioles, again, make it easier for oxygen exchange to occur. Now, you must remember that corticosteroid therapy will be for short-term use only, not long-term. Okay, and as always with your corticosteroids, you always want to worry about how this is going to increase hyperglycemia, how it is going to immunosuppress your patient, so make sure you're aware of that, especially if they are diabetic. Okay. Number 5, you apply O2 therapy, but make sure you use the lowest amount of O2 possible. Okay, because these patients do retain COPD, that is going to affect how much oxygen therapy you give. Typically, you want to start off with 2 liters NC, or maybe even lower. I don't know how much effect 1 liter will do, but in some instances, 1 liter does cause great effects. But you always want to start off at the lowest setting possible. And then after that, you will always look at your ABG to determine if you need to increase or decrease the amount of oxygen therapy that you give. Okay, so this is where the ABG comes into play drastically. Again, you must always look at your ABG. The physician will look at the ABG and then will say, you know what, you need to titrate that more. You might need to decrease it or increase it, again, depending on your ABG. So you always want to look at your ABG to determine your oxygen therapy. Number 6, surgical therapy. Something known as lung volume reduction. Now, what happens in lung volume reduction is part of the lung that is severely affected with these alveolar changes with this emphysema is resected. In lung volume reduction, those areas are resected, they're removed. And this is done in attempts to help increase oxygen exchange. Okay, so the parts of the lung that are most severely affected are removed, hence the name lung volume resection. Or, lung volume reduction. Something else can be done like a lung transplant. Number 7, you will teach, if your patient doesn't know how to do so already, you'll teach him to perform pursed lip breathing. Okay. So here, again, you're going to just tell them to prolong their expiration time, their exhalation time, okay? So if they don't know how to do pursed lip breathing, you will teach them. Number 8, you will do something, or you will instruct them to perform something called huff coughing. Again, this will be used to help rid the body, help rid the chest of those secretions. Okay, so this is done in an attempt to clear secretions. You can also perform something like chest physiotherapy. Again, this is done to mobilize those secretions. We'll tell them to change their position frequently. So you can put them in a sideline position. You can even put them in a Trendelenburg position. Now, in some beds at the hospital, they have the potential to move the patient by themselves, so the bed actually changes in position. If you have those beds, awesome. Okay, but you want to encourage frequent position changes. Again, that's going to help get those secretions out. This is a big one. I've seen this on a lot of practice questions, and you will tell them to use a flutter mucus clearance device. Now, just like the name says, this facilitates the removal of mucus secretions. Okay, so again, a flutter mucus clearance device. Number 12, you will also tell them to take nutritional supplements. You want to give them things that are easy to chew. Remember, these patients run out of breath very, very easy, so you don't want to give them things that are very, very hard to chew, that take long periods of time to get down, because again, they will become hypoxemic. And yes, they do need a lot of protein because they're using those accessory muscles to breathe. So please make sure that they do have nutritional supplements.